I also have an appointment at the university, and I've been kind of chairing these meetings for maybe a couple of years now. And I get the privilege of introducing our speakers. So let me start with Alison, who will also be starting the talk. And again, if you're not sure where you are, our talk today is Findings from the Washington State 2021 Syringe Services Client Survey. And Alison has joined ADAI, that's the AIDS, Drug, and Alcohol Institute, in 2017. And since then, she's been providing education on overdose, opioids, and working on the website that is stopoverdose.org. She specializes in health education and healthcare access around drug use and health. And those of you who've been on the lunchboxes recently also know I've asked the speakers for a little fun fact. And Alison's was that she enjoys river snorkeling here in Washington. And she does admit it's cold, but wears a wetsuit. And she's seen lots of fish, including some huge ones in the current of a cold water creek going into the Wenatchee River. And now Caleb Banta-Green. Dr. Green is principal research scientist at ADAI and also an affiliate professor at the University of Washington in the School of Public Health, Department of Health Systems and Population Health. His main area of research is substance use disorders involving opioids and stimulants and interventions to support recovery and reduce substance-related harms. He's particularly interested in interventions that are accessible to all people, including those who are most marginalized, unhoused, using services that support the health of people who use drugs and in the criminal legal system. And Caleb's fun fact is that he was a bike messenger in 1990. And when he was there, he had a handle of happy-go-lucky. And we're so happy to have you, happy-go-lucky. While they're talking, feel free to put clarification questions in the chat function, and they will be planning to pause for other questions. So I will shut up and let Alison take it from here.
All right. So a little bit of background about me that's probably relevant for this group compared to some other groups is prior to coming to ADAI, I worked in 2 different health departments, one at the Vermont Department of Health as the Viral Hepatitis Prevention Coordinator, which is where I started working with Syringe Services Programs. I oversaw the state's then 3 syringe service programs and worked on data collection with them and TA. And then I also worked in Humboldt County, California for 3 years, including with our HIV prevention program, doing syringe exchange and naloxone access and PrEP. So really appreciate being here today. This is definitely, a huge area of interest of mine, and just appreciate you attending. I want to shout out to Sarah Glick, who was a big part of this research. So today we'll be talking about our results from the 2021 Washington State Syringe Service Program Health Survey. This really is a huge collaborative effort. Susan Kingston isn't on this call, but she really organizes all the syringe services programs. Sarah Glick, who's on the call, does the King County data collection and really develops the survey with us. So it's this really great team effort, collaboration between us at ADAI, Public Health Seattle, King County, and the Washington Department of Health. So, next slide. So I just want to start with our land acknowledgement, and I'd like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the Indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our Indigenous neighbors. And to me, this slide is especially important in the context of our Syringe Services Program survey. As you'll see, American Indian Alaska Natives are overrepresented in this sample. I think they're important partners and important groups for us to be working with and for. Next slide. So today we're just here's our rough agenda. survey methods and setting overview, demographics of participants, substance use, smoking patterns and interest in safer smoking supplies, overdoses on opioids and stimulants, and health and substance use disorder care. We'll have time for discussion. Next slide. So big thank you to the Syringe Services Program staff and volunteers for the time and effort to make this survey happen. And thank you to all the SSP participants who trusted us with their personal info during this survey. So doing the survey, during COVID posed some challenges, partly because, programs had less staffing than they may have in the past. Hours were cut, but this is an important survey for those programs, and the people we surveyed also understood why it was important. So just a huge thank you to them. It obviously wouldn't happen without them. So we're just going to do a brief overview of the survey, and then Caleb will dive into data. So as I mentioned, the survey is developed by ADAI, Public Health, Seattle and King County, and the Washington Department of Health. The Syringe Services Programs provided input to topics and questions. We've conducted this survey every other year since 2015, and it really built upon work that it was being done by Public Health Seattle and King County prior to that. We've also conducted 2 rounds of qualitative interviews in 2018 and 2021 to get a bit of a deeper dive into people's motivations for substance use and help us have a better understanding of survey questions. So if you want to check out the full range of the work that we've done really since 2015, we now have a new webpage where all of that work lives, and it's linked right here. Next slide. So Syringe Services Programs, given that we're on a call with people who work in HIV, this is probably overview for all of you, but they are a diverse group of organizations that provide harm reduction services to people who use drugs. These organizations all are structured, pretty differently. Some are at public health agencies, some are nonprofits, some are at treatment agencies. Some Syringe Services Programs have a fixed location where clients go to obtain services, and some operate out of a van or other type of mobile service, or a mix of the two. Services include syringe exchange and safe injection equipment, naloxone and overdose education, HIV and hepatitis C testing, referrals to substance use disorder treatment, housing and medical care, and some in Washington also offer on-site low barrier buprenorphine and other services related to substance use disorder treatment. And this is really a growing and evolving area for these programs. Next slide. So why do we conduct surveys at Syringe Services Programs? We want to learn about and from people who inject drugs. We want to support important public health programs through partnership and collaborative data collection. We also want to improve services and supports for people who use and/or inject drugs in Washington State. Next slide. So here's our methods. It's an anonymous survey, and the goal is to interview everyone who is willing, which is not always possible. Participants received candy as a thank you. They got to choose from a really great selection. Though for Yakima, we tried not to have too much chocolate because it's so hot. But we administered the survey verbally. Either ADAI staff like myself, Nicole Brandt, Susan Kingston, Mandy Owens, or Sierra Teat, who is a grad student who's working with us. SSP staff administered many of the surveys, and as well as volunteers. The majority of surveys were collected on paper. However, 3 sites entered surveys directly into the REDCap online survey tool. Participating SSPs were given the results of their data, and specific sites own that data. So for example, if you want to know what was happening in Thurston County, I can't share that data with you. You have to go to that program directly, and they will be able to share it. So just good to know. And statewide data was analyzed using SPSS. Next slide. All right, I'm going to hand it over to Caleb.
Great, thank you. And I think I'll go through demographics and substance use, and then I'll pause and see what questions folks have. This is where respondents were, 20 counties, 21 organizations. And the way this is color coded is, so for instance, in Spokane, it's orange, and those are all folks who went to the Spokane exchange, and then the dots are the zip code of where they slept the night before. So you can see folks coming from quite a ways in Spokane as an example, and in fact in most places. Here, we're going to share data for 955 respondents who reported substance use in the last few months. There were a few folks who did not report substance use who did complete the survey. We did not include them in this analysis. And you can get a sense of the numbers here. I should say this 955 is lower than we've had in our last few surveys. I think we've had 1,100, we had almost 1,300, but it's still a lot of people. It's still really a tremendous effort that we're seeing across the state, getting these folks to participate and share their information. So on the demographic side, a mean age of 40, a mean age of 38, you can see really a very broad distribution and a lot of numbers as well in that sort of young adult side also. Gender, 58% self-identified as a man, 40% as a woman, a little less than 1% identified as non-binary or a trans man or trans woman. And to Alison's point earlier, in terms of race, ethnicity, people could report multiple categories, pretty representative of Washington state as a whole, with the exception that American Indian, Alaska Native folks are definitely overrepresented substantially. Interestingly, similar proportional overrepresentation that we also see, unfortunately, in overdose deaths. So just, sort of this 2 to 3 times higher representation here. Housing status, 39% identified as homeless, 28% unstably housed, 33% permanent. That's pretty similar to previous years. I will be cautious today, generally, as I always am, about not reporting sort of formal trends. It's a repeated cross-sectional survey. And certainly, we sort of see folks coming in and out of this eligible population. And in particular, on the opioid side, where we've had over 10,000 people start on treatment medications in the last few years, 1,500 just through some of our programs at syringe exchange sites. So this is obviously just those folks who are actively using syringe exchange at any given time. And if there's more people engaged in treatment on the opioid side, it may not be there's a decrease in opioids, just there's more people in treatment as opposed to actively using. So try to be mindful about how to represent those data. 92% of people were insured, most on Medicaid. About a quarter have been in jail or prison in the past year. I will say that is quite a bit lower than we've seen in previous years, which makes sense given the Blake court decision decriminalizing drugs temporarily and subsequent laws that made them misdemeanors, as well as COVID. Similar proportion as previous years have been in emergency room in the last year at 53%. That's a lot. If you're not used to looking at emergency room utilization data, 53% in the last year is a lot. Sexual partners, in the last 12 months, have you had sex with? So among men, actually that N is wrong, but ignore that. Among men that's identified as male, the majority, 70% said women, but you can see the other distributions here, 20% were not sexually active, 14% reported sex with men. And then among women, the majority, 82% with men, 11% women, and then a smaller proportion, 14% no one. So I'm going to pause it really. Actually, I'll go through substance use and then I'll pause. Unless you see comments champing at the bit, Alison, let me know. So in terms of the substance use, what we see here, I'm going to report this in a few different ways, so bear with me. We're reporting here in this first column whether the substance was used at all in the last 3 months. And then in this column, whether people self-identified it as their main drug. We did not define main. We really left that up to folks. In previous analyses, it's certainly associated with frequency of use, but it can be about more than that. It might be the substance somebody used first. It might be a social group they identify with. It might be frequency of use. It might be tied to route of administration. But you'll see some reasons we retain that variable because there's some interesting things we find with that. So in terms of use in the last 3 months, 86% reported methamphetamine use, 69% heroin by itself, 48% meth and heroin together as a goofball, 42% fentanyl, and we had 18% reported fentanyl use in 2019 statewide. So that's a very large proportion reporting fentanyl use. And then you can see alcohol, benzodiazepines, opiate medicines, cocaine. We tend to see more cocaine in the King County area than, for instance, Eastern Washington. And then identified as main drug, a little bit of a different sort of flip here. Most common was heroin, identified as their main drug, 41%. 29% said methamphetamine by itself. 21% said goofball. I won't go into a lot of this. It can come up later. Sarah and Julia can comment on it more expertly than I can. This is a larger proportion statewide reporting goofball use overall and as a main drug. So I'll mention that very quickly. Oh yeah, Alison put that in there about the N for men. Thank you. So I'll leave that there for a moment, but just to mention that, we're primarily looking at heroin and methamphetamine, either separately or together, although fentanyl is coming on rapidly. And I'll show you something here that while 3% identifying it as their main drug, in terms of frequency of use, 14% of people use fentanyl, so they used it 5 or more days a week. So this is one of those where, to me, main drug doesn't tell you everything about fentanyl. We have a much larger proportion who report using it daily or near daily. So now to sort of explain this graph a little bit. So in yellow, or whatever color that is, 86% of folks use methamphetamine, most of them, 82% overall in the last week, have 5 or more days per week. Generally similar pattern with heroin, a little bit lower overall use, but a similar proportion using near daily. For goofballs, about half reported using, about a quarter using near daily. Fentanyl, again, 42% using, 14% near daily. And then you can see alcohol, benzodiazepines, cocaine. And then in the olden days, people use speedballs, and that's just not that common anymore. So again, here's this main drug variable. On the left side, this is among those who said their main drug was heroin. 82% reported stimulant use in the last week. Conversely, those who said their main drug was methamphetamine, just 27% said their main, so they use any opioids. So when we look at polysubstance use, there's a bunch of different ways to look at it. There's frequency, there's identity, there's sort of self-identity. And so just sort of saying people, oh, they use heroin and meth in the last week, that doesn't tell you the whole picture in terms of what might be most salient or relevant for them, or what might be most frequent, or sort of how they use. Are they using concurrently or sequentially? A lot of subtlety in there. This is brand new question, and let me explain the way we put this here. So around the last time you used fentanyl, the first part of the question was it on purpose? 2/3 said yes, 1/3 said no. So 2/3 said they used fentanyl on purpose. Doesn't mean they wanted to, but they used it knowingly and on purpose. And that's a whole thing to kind of unpack. So that's interesting right there, because I would say certainly 3 or 4 years ago, what we were hearing was that most people were not using on purpose. They actually were using blue fentanyl M30 pills, or blue M30 pills that they thought might actually be oxycodone. Now they almost never are. I think people know they're fentanyl, and so they may be using them on purpose. And using on purpose may be that it's a person with opioid use disorder and they can't get heroin, and they don't want to go into withdrawal, so they're using fentanyl. They may not want to be using it. It may not be their preferred substance, but it actually is on purpose in that context. So that's a lot to kind of unpack. We don't have all that subtlety in this survey. And then what we looked at was, by purposefulness of use, what did the fentanyl look like? So among those who said they used it on purpose, 2/3 said they used it in the pill form, 23% in a powder form. And we may go into this a little bit more in conversation, but that 23% to me was a surprise, because we really only started hearing about fentanyl in powder form with any prevalence about a year ago. And it felt like we were hearing about it more in the context of people who historically injected heroin, who are now perhaps injecting fentanyl. So the fact that we're at 23% just shows me how quickly sort of things are shifting in the fentanyl market in terms of a lot of things. What type of product is out there? What's the form? Who's using it? What routes of administration, and so on. When they said it was not on purpose, 3/4 said it was mixed in with other drugs. This raises a bunch of questions. Was it actually mixed in with other drugs? Was it mixed in with other drugs in a large proportion? Was it purposeful? Or was it a false positive on a fentanyl test strip of a methamphetamine sample? So we don't really know what that means. There's a lot to kind of dig in there, and people don't necessarily have all of the information. We do know there's some nice research that shows that people are able to self-discern fentanyl compared to heroin, which is not a surprise. It's a much more rapid rate of onset and a very sharp peak and a very rapid decline. So people can feel the difference. What we don't know here is sort of what exactly the 74% represents. Okay, I'm going to pause there for a moment and see if people have any questions or comments, or also if Julia or Sarah have anything they want to throw into the mix. That's a kind of a complicated slide I just showed, and I'm wondering what thoughts people may have on that, if any.
Caleb, you mentioned test strips. Can you unpack that a little on
Oh, sure. Yeah.
today and what they find?
Yeah, and I'm not an expert on these. So here is a fentanyl test strip. It is really, it is intended for urine samples, not for drug testing itself, although that's how it's used. You have to dilute it down. And so it's really a binary result. There's fentanyl or there's not fentanyl. And so if it's not fentanyl, it could be something else. If it is fentanyl, if it tests positive, you have no idea how much it is. It could be a trace amount. They're very sensitive tests, or it could be a lot, or it could be a false positive. So they're a tool that is out there, and there's some nice research that shows distributing them and people using them are more likely to take harm reduction steps after they test positive as fentanyl. To be really clear, if I have opioid use disorder and I'm in withdrawal and I have an opioid in hand, even if it tests positive as fentanyl, I'm very likely to still use it. I am in withdrawal. I have an opioid in my hand. I may be more likely to take some harm reduction steps. And the test can be useful in that way. It also can be useful as an engagement point. But there also is a move, and King County will be doing some much more comprehensive drug checking. That is a whole other conversation. That's pretty complicated actually, but could give you much more sense of a much broader array of substances. We think right now most of the fentanyl that most of the product that appears to be fentanyl, we think is fentanyl, really is fentanyl. It's not often these sort of other fentanyl analogs or other things based on crime lab police evidence testing, but that's obviously a very different sort of sample that we're looking at. So that's a little bit on fentanyl test strips. It is sort of a newer harm reduction tool. They can cost about $1 each. And if you think about it with fentanyl, I should say as well, with heroin, a person might use 4 or 6 times a day. A person might use fentanyl 10 or 15 times a day. Imagine now that are you going to test your fentanyl every time you use it for a year for thousands of dollars? Probably not, is my guess. But so just trying to figure that out in terms of what is for the harm reduction sort of service mix. I think there's more stuff in the chat. Nothing. Okay. All right. Thank you.
Could I ask a quick question?
Please.
Sorry if you already said this, but on that last slide, how did the people know if they did not take fentanyl deliberately? How did they know? Was it just what you're saying? Were they testing?
Well, that's what we don't know, right? I don't know how much was the. They said that they didn't use fentanyl on purpose, and the form was it was mixed in with other drugs. That is possible, and I should elaborate on that. We were very close to the state crime lab. We very rarely see fentanyl in what appears to be other drugs. And things that appear to be black tar, it's almost always heroin. And samples last year that were all crystalline and were methamphetamine was never fentanyl. Doesn't mean that there couldn't be fentanyl in some of those drugs sometimes. It just means in the samples we have seen, which is the police evidence testing, we just almost never see it mixed into other substances. And the problem with these tests as well is that they're super sensitive. So, somebody could, be processing drugs before sale, and I got a bunch of stuff on a table, and there can be some cross-contamination, which I used to think was like this theoretical thing, and now I'm much more convinced is something that definitely can happen in that processing and packaging and putting it in different baggies and such. So part of it is it might be a result of a fentanyl test strip. Part of it might be impressionistic. Somebody told them. Part of it might be sort of impressionistic. They felt the effect, and they could be correct or they could be incorrect. So it's really a hodgepodge.
Thanks.
But it makes sense, right? I didn't use it on purpose. What was it in? It was mixed in something else. You don't not use it on purpose, and it's in a blue pill that everyone knows is fentanyl now. So again, sometimes our job is to document the obvious, but it is nice when data roughly align with what we think is going on. Always makes us happy. Okay, I will dive back in. Let's see here. Okay, so smoking. So the fentanyl questions are new, and a bunch of these smoking questions are new. And I think this is a really profound topic. And I'll also mention, maybe ask Alison if you would be so kind to dig up our smoking information brief that we had a student put out about a month ago, which I think you might find interesting for context. But here's the questions we asked for smoking here. So let me slow down on this novel way of approaching data that I'm still getting comfortable presenting on. So this is looking at routes of ingestion by drug use reported in the past 3 months. So for goofballs, that's the combination of heroin and methamphetamine. The majority said they injected only. A third said they smoked and injected. Very few said they only smoked. A pretty, to me, interesting and a bit of a surprising result. And again, this is 93% of folks at Syringe Exchange in this survey are inject some drug. But among those who use fentanyl, only a quarter only injected it. So even among this population of folks who mostly inject drugs, the fentanyl is not infrequently, but only a quarter of those report injection only, a quarter smoking and injecting, most commonly smoking only. So among our group of folks who mostly inject some drug, half of them, if using fentanyl, are smoking it. So that's a lot of smoking of that substance. And as I mentioned, high frequency smoking typically. For heroin, 45% say they injected only. Just to be clear, 10 years ago, I think, I'm kind of looking at Sarah, but she can't tell. I'm pretty sure that for heroin, we were looking at about 90% would have reported injecting only. Smoking has become more common, particularly among younger adults about 7-8 years ago. But again, so heroin used to be predominantly injected. Now we're seeing this mix. And then methamphetamine, among the population of Syringe Exchange, a minority are injecting only. And then you see a lot more smoking. If you were looking at the total world of folks who use methamphetamine, injecting and or smoking, you'd see an even larger proportion smoking. So this is a little bit of a distribution. To me, what stands out is this very large proportion smoking fentanyl. Also very relevant context. These folks smoke other things. 83% smoked or vape tobacco, and over half cannabis. So it isn't as though I think one of the reasons I think for that context is to say that if you introduce smoking equipment to people who inject drugs, you're not going to magically turn them and make their health habits more harmful when they start smoking. They're often already smoking these substances, and they're often already smoking other substances. Smoking is a major thing that is happening. How do we reduce the harm associated with that smoking? Let me take a little bit of time on this one. For what are people's main reasons for smoking rather than injecting? So for those who inject opioids, who also smoke them, what are their main reasons for smoking opioids? 23% said it was because they cannot hit veins anymore. Next most common was sort of the sociability of smoking, generally smoking being more available. And then here, reduces the risk of overdose. These are small numbers in proportion, but there's a bit of a difference here where it looks like a somewhat larger proportion of those on the opioid side of things talking about smoking, reducing the risk of overdose. That is, I should be clear, in my understanding, not being a medical provider, there probably is a lower risk of overdosing on smoking heroin than injecting heroin. I don't have any, and I've asked a number of providers, it doesn't seem like you'd really be reducing the risk of overdose from smoking of fentanyl or methamphetamine because they're both so high potency. But for those who are using heroin, there probably is a bit of a reduced risk of overdose for smoking. And again, there's that difference with stimulants. And then in terms of preferring the high from smoking, it looked like a somewhat larger proportion on the stimulant side of things. Now looking at this from the perspective of those who inject stimulants who also smoke, the most frequent reason cited was smoking is more social. And we are aware of folks who are providing more harm reduction services, including places where people can consume drugs in the United States. And it sounds like for those who are smoking for stimulants, there often is this more social component where people will hang out for a while, like people will with other substances, such as beer and alcohol, will hang out for a while in a more social environment and use those substances for a while. So that smoking is a more social thing, I think is an important thing for us to think about when we think about the types of services we want to make available to folks that they actually want to utilize. I see lots of stuff in that chat, so I can see if there's any questions. Okay. Yes. Oh, thank you. Yes, that. Okay. I don't think there's anything I need to respond to, but good to see those comments. Oh, do you have any data on smoking rather than injection for infection reasons? Let's look down here. What are we seeing?
That
Overdose?
didn't come up, but people did say that it was can't hit veins anymore came up, and people did talk about protect veins or save veins. So it wasn't specifically like abscess or endocarditis or things like that, but a lot around vein health.
Right. There's I mean, yeah, not directly, right? So you get faster and easier, a negative view of injection, which we don't know what folks mean by that. I can guess it's probably not that infection per se. And then again, there's this sort of can't hit veins or protect veins. So right, I hear you. It's not about infection specifically. I didn't look at those miscellaneous data, and I don't know if you did, Allison, or maybe Susan did, but I don't know whether
I did, and that didn't come up. A lot of the miscellaneous data was people talking about not so much why they smoked or injected, but why they used the drug.
Okay.
So
Okay.
It wasn't especially useful for that.
It's a super good question though, right? I mean, this is a really important slide that I'm still trying to sort of digest the implications of. But as we think about the need for more services for folks who smoke drugs or people who inject who would be willing to smoke drugs, segue, let me talk about that. So we asked this question: would you like to get free clean pipes or foil to smoke opioids or stimulants among those who had injected? So 3/4 said yes. Before I go on, 1/4 said no. So that's important. There's some folks who inject and do not want to smoke, but that is a minority of people. For those who do say they would be interested in getting smoking equipment, if you got that equipment, would you inject less often? So self-reported future behavior, take that for what it's worth. 2/3 said yes. There are a couple of pieces of research in that information brief that Alison put that do, from an observational perspective, self-report, after distribution of smoking equipment, we do see significant reductions in injection. Doesn't necessarily go away, but the frequency reduces. So this does coincide with the literature that is out there. So here's another angle in all of this, which I think is really interesting, which is about the peer networks of people. So folks who do, how many folks do people know who do not inject at all? So among this population, we ask people, how many people do you know who smoke substances but don't inject them, opioids and stimulants? 91% of some had sort of the picture of those Venn diagrams, those social networks overlap between people who inject and people who don't inject. And often those social networks are quite large, with over half of them knowing 6 or more people. And I think about that in terms of the those networks intersecting, that the people who come to Syringe Exchange could distribute information and materials, but also if, quote, syringe exchanges or harm reduction sites offered more services for people who smoke, whether it's smoking equipment or drop-in wound care or mental health or addiction treatment, there's something to draw those folks in, and they're not, you know, we have people who can help spread the word really quickly. And that's really exciting to me, is to see that those social networks are not unrelated to each other, that they do intersect. Any things there before I go on? That was a lot of stuff I just put out there on the smoking side. I wonder if people have any questions or thoughts on that. And I should say also that, you know, as someone I realized one of my fun facts was that I was a volunteer for the AIDS prevention project at Seattle King County Public Health in '93, so a little while ago. But I think what's interesting, just from a messaging and language perspective, that we're still getting our heads around, is that, you know, the case for syringe exchange and in terms of HIV risk and other bloodborne pathogens is really clear and straightforward. For smoking, it's not as straightforward. We're more talking about preventing burns and wounds and cuts, where there is an opportunity for bloodborne pathogens to be transmitted, much lower, obviously, than directly sharing injecting equipment. So that case is not as strong, and it's not as strong on a different perspective, from an overdose perspective. I do think, though, that it's really important from an engagement perspective. We have a bunch of people out there who are smoking drugs. I believe that a majority of people now dying of overdoses, which are predominantly fentanyl and methamphetamine, are smoking, and likely many of them not injecting. And we don't have any immediate way to sort of offer something to be of service to people, and trying to think about harm reduction services of being of some impact in the short term, in terms of infectious disease, but also in terms of wounds. And then also further on about the engagement piece around that. And I'm really interested in, as we do roll out more smoking supplies, what are the short term, what are the proximal and the distal longer term impacts of that? both in terms of health, but also relationships and trajectories and kind of off ramps that people might be seeking from either their substance use or substance related harms. Okay, I'll jump back in to data. Now, see what I do, all back to the beginning. Apologies. Okay, so hang on, because I've got Zoom overlapping my. Okay, so looking at drug injection frequency, the vast majority of folks are injecting near daily, 5 to 7 days a week, mean of 6 days. On average, how many times do you inject? Most common sort of that modal group is 3 to 5 times a day, with half of people, a mean of 3.5. And then how many times do you use the syringe before you get rid of it? 73%. So that's super exciting, right? And there's just a ton of syringes that are out there that people are using usually once, which is great. Injection-related infections. 38% reported an abscess or skin infection, which is pretty interesting given the fact that they're usually using a syringe once. We still see quite a bit of abscess and skin infection. About 6% reporting a blood clot or blood infection, and 2% endocarditis. How many other people are you getting syringes for today, not including yourself? It was an average of 2 people. And how many times did you get syringes from an exchange in the last 30 days? An average of 3 times, so not quite weekly. Most syringes, I think every syringe exchange is open at least weekly, but as opposed to King County, which has a lot of hours, some places may be open just 2 to 4 hours a week, an afternoon a week. So a lot of variability in terms of access. In terms of HIV, hepatitis C, and syphilis, these are some newer data, some of them newer to me. So on the hepatitis C side of things, you can see most people have been tested. 37% have been diagnosed with hepatitis C, 41% have received treatment, most have finished. 57% haven't received treatment, and most would be interested in treatment. So that's great. So there's, it's a sort of, we're getting a bunch of folks, we're getting them engaged, they're getting onto treatment and they're finishing treatment, but there's still room for improvement and there's still interest there. So plenty of still work to do on the hepatitis C side of things. HIV, we don't ask about HIV positivity. I think we did a couple years ago in King, but we are not doing that now. But we do ask whether people have had an HIV test. Almost 90% have, half of them a year ago, half of them the past year. And then in terms of syphilis, so in the last 12 months, have you been tested for syphilis? 23% said yes. And among those, most did not have it, according to what a healthcare provider told them. But we are seeing the proportion here, about 13% of that subgroup who did report having syphilis. I'm going to keep going here. I don't see any immediate questions. Okay, so for overdose, let me break this down a little bit. So there's a lot here. So in terms of having an opioid overdose, so self-report of having an opioid overdose, 24% reported having an overdose, 11% had 1, and then a remainder 2 or more. And you can see it's 6% with 3 or more overdoses. And we're going to dig into these data more because I have some suspicions that those folks are probably more likely to be people who use fentanyl. So I'm going to be looking into that over the next month or so. So speaking of that, so among those, so in terms of overdose, it was 24% overall. It was 20% among those who used opioids, but not fentanyl. So 20% self-reported overdose among those who used opioids, but not fentanyl. 27% among those who used fentanyl. It is likely that fentanyl is several times more fatal than heroin. So this being a higher proportion makes sense. My guess is it's actually much higher than that. Unfortunately, I think we probably have survival bias in these data, that there's so much more lethality with fentanyl. And for those who aren't familiar, we had, I believe it was a fentanyl overdose death a day in King County last year. Huge numbers. So I think the bias in these data is pretty strong. So we already see this pattern. My guess is that it's unfortunately blunted by the mortality rate due to fentanyl itself. In terms of witnessing an opioid overdose, 61% had seen an overdose. Many of those folks, half of them had seen 3 or more, so really common. We didn't even ask it again because we've gotten to such a high proportion, but in 2019, over 80% of people at the syringe exchange had naloxone. So naloxone, very, very prevalent and widely used and disseminated. So looking at acute consequences of methamphetamine, we've been struggling for a while with language. We actually kind of like this language. We've used it again. We have a student right now working on a paper around this that's working with Sarah. So in the past 3 months, not 12 like opioids, past 3 months, have you ever felt like you were losing your mind, manic, or psychotic while on methamphetamine? So severe psychiatric symptoms. 30% of people said they had those symptoms. Having severe medical or physiological symptoms, heart attack, stroke, or seizure while on methamphetamine, 19%. Then overall, 12% of those who use methamphetamine had been to the emergency department due to either one of these problems in the last 3 months. So able to break that down a little bit more. There's been some confusion in the past about the word overdose. Doesn't really conceptually people don't self-identify who use methamphetamine as these events. People don't seem to call overdoses, but I think when we get more specific about the symptoms, they do respond to them in what we think is a meaningful way. I'm going to pause there and see if people have any questions or comments on the overdose side of this in terms of opioids overall, witnessing fentanyl, methamphetamine, any comments or questions on the overdose side of this? Okay. Go back.
They're probably just chewing their lunch.
That's cool. I have no problem with that. I just want to make the offer. Okay. Health and substance use disorder care. So there we go. So for COVID vaccination, and remember this was in September, October, so we weren't quite fully in booster land. 63% were not vaccinated at all. And you can see here the proportion who were, quote, fully vaccinated with Pfizer and Moderna or Johnson & Johnson. But again, about a third of folks have been vaccinated to some degree. Among those who had not gotten vaccinated, do you want to get vaccinated? Most common said no, which is pretty interesting, but a pretty broad range across places, across sites. So this range is by site from 50 to 95%. And there are people who do want to get vaccinated, and there are folks who are unsure. So there certainly is more room. And we have a colleague in Walla Walla who just got a grant to really work on trying to encourage and promote and test different ways to actually get folks who use SSPs to get COVID vaccinated. So we'll see what comes of that. But that's what we found around COVID. And then in drug treatment in the last 12 months, 2/3 said they've not been in any treatment. Most common was buprenorphine or methadone. And you can see the other forms of treatment that people had received as well. I will mention that people may be aware that in King County, there's buprenorphine pathways, which is available to folks with sort of rapid drop-in access to buprenorphine. And then we've also done some similar work in 6 other communities around the state to expand low barrier access to buprenorphine at Syringe Services Programs, and a bunch of FQHCs, particularly in King County. I started doing a lot of low barrier buprenorphine. And if you didn't see the Seattle Times Pacific Magazine piece 2 days ago around life after opioids about low barrier buprenorphine, it was really, really, I thought, really nicely done. Talked with folks at Country Doc, as well as in Olympia and out in Alma around low barrier buprenorphine, which is pretty exciting and a very humane and thoughtful piece, I thought. Let me see. Dr. Grandy's, speaking of Olympia, Dr. Grandy was in that piece. When someone says that they experienced or saw someone else overdose on meth, what do you mean? Oh, I apologize. We do not have a question about seeing other people experience an overdose on meth. That question is around opioids. Sorry if I was not clear on that. So that question is around seeing an opioid overdose. The questions around meth are about people self-reported their own experiences.
And I just have one insight into that, which I think Cindy might be aware of, being that she's worked with many clients. Many people who use methamphetamine don't identify it as a risk for overdose as we think of it. They might talk about overamping, or they might think about specific symptoms. But many people who use methamphetamine don't think that they're at risk for an acute event in the way that they do with opioids.
Yeah, and when I started in this line of work back in '01, I remember meeting with a medical examiner's office, and what I was hearing was methamphetamine is not as acutely cardiotoxic as cocaine, which is, well, even though there was a ton of methamphetamine 20 years ago, we were not seeing that many overdoses. We were seeing a 10-fold higher overdose rate now, fatal overdose rate for methamphetamine than we saw back in the day. So part of this, the reason people thought that is we all thought that 20 years ago, and it's very clearly not the case. And particularly since half of those methamphetamine overdose deaths do not involve another substance. So pretty clearly there are some serious consequences due to methamphetamine. Let's see, a few more things. So data was collected, during COVID. So a lot of these syringe service programs are ours, and the nature of the transactions, how it became more transactional, less relational, things were affected in that way. Certainly, this is ultimately probably a convenient sample, even if it's an attempted census, so it may not be representative of all people who inject drugs in this state. And I think it's probably pretty clearly not representative of folks who maybe only smoke substances. So patterns have changed. It really does look like we're seeing more methamphetamine use and certainly more fentanyl use, a lot more smoking, even among those who also inject. I think the SSPs are clearly an essential service for people who use these drugs and are part of this continuum of care. They're really well positioned, these sites are, to expand service to address substance use and overdose. And we sure need to be involved in people who use substances and figuring out what services make sense. So one of the things we're likely to do, I'm guessing, is, and what Alison's done really nice work on, is in these off years. So we did the survey in an odd year and an even year, go back and do qualitative work, is to unpack a little bit more about what services people would like and how they would like them, and so on, to really get good, rich information there. So the syringe exchange survey, this large scale survey, is a really nice place to sort of get a sense of, is something new happening and what's the scale of it? And then the qualitative work is a really nice chance to sort of dig in and figure out, okay, there's something going on, help us understand more about what it is and how we can be of service ultimately. I do want to share this with you. This just was created, I guess, last week. I'm really excited about it. So our group is the Center for Community Engaged Drug Education, Epi, and Research. And we now have all of the syringe service program surveys that we've done on one page, the biennial surveys here. And then if you click on this, you'll see here's an example of a subpage that gives you a little more detail about what are the new topics, where the participants, where's the report in a webinar. Also, not all the questions are asked every year. There's questions we no longer ask about, do you have naloxone? Were you hooked on prescription opiates before heroin? Do you want to stop or reduce your use? We got to kind of a saturation point or a consistent response on those, so we then drop that question and put in new questions. But that's a reason to look back at the old surveys if you're interested in those topics. And then also the qualitative work that Alison's done a really nice job on in terms of last year's looking at perspectives of people who use methamphetamine about their interest in stopping or reducing their use, building on Vanessa McMahon's dissertation work. And then this even broader question that we looked at several years ago about what services people would want to help them stay healthy. So those are our emails, and I would love to hear any more thoughts people have. Maybe we'll go about 5 more minutes and give people a little break. But any questions or comments or feedback?
I see a question from Jimmy.
Yep.
Oh, do you see regional differences in Washington for use of substances and/or route, rural versus urban, west versus east, closer to Canada, or is it fairly similar across the state? I haven't dug into that this year, so I'm not sure.
Yeah. Things are becoming more and more similar on average across the state. I mean, when I started, things were really different across the state, and methamphetamine became ubiquitous, and then a pathways when methamphetamine came up from Mexico, all the rest of the drugs came up, prescription opioids, and so on. And so there's much more even patterns across the state. One thing that was different in 2019 was more goofball use in the King County area, and we're seeing that now more consistently across the whole state. So that's one thing. So we've not asked about HIV status because I think there was concern that it was sort of too sensitive. We did ask it a few years ago. And this is kind of a brief street intercept survey, and there still is a lot of stigma, even in the context of folks at SSPs around HIV. I don't know if Sarah wants to say anything more about what they found around HIV status, because they are asking it in King County.
Yeah, thanks, Caleb. I guess I just wanted to first of all say thank you for your presentation, you and Alison. and just, for this ongoing collaboration. It's been so great working with you all and being able to share our data. Brett, to your question, I guess specific to King County, we're going to be putting out a King County specific report, hopefully in the next month or two. And our surveys are very similar, but the King County one has some differences. And one of those is we focus a bit more on HIV, including status and testing and PrEP. So we'll be reporting on that from the King County specific lens. So you can be on the lookout for that. And I will just also add that this statewide survey is really unique. And to my knowledge, there really aren't any other states that do such a comprehensive and systematic survey of their syringe services programs every year, every other year. So this data that we have, I think we sort of maybe take it for granted, but it is really special and just very useful for all of us. And so we're really happy about that. And on another project I work on, we're actually using this model with other programs across the country because so many people are excited when they see how it's worked and what data we can produce from it. So thank you to ADAI for the continued collaboration and for being here today.
Thank you to King County for modeling earlier syringe exchange data.
Well, I can't take credit for that. That was my predecessor.
I said King County, the whole county.
I have one more follow-up to Brett's question too, which is that the statewide syringe services programs give us input into what questions will be good to ask. And I believe they've said that HIV status would be really sensitive, especially in rural areas. And similarly, we asked whether we should include questions about sex work, and they said no, that it is too sensitive, especially in a rural area. So.
And it is. I mean, you saw those pictures earlier. I mean, it literally is, a paper pencil street intercept survey. And we certainly try to give people some privacy and some space from other people, but it's often boom, 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 people coming in and exchanging, and it can be a little hectic. So just in that context, trying to be sensitive where we can. All right. So all of this stuff is online. To back up what Sarah said, I'm very heartened by this. I really like this sort of mixed methods approach that we're getting into a cycle of doing. I think is really exciting. These data are really invaluable. I mean, I'll just share with you the very first time we did this in 2015, and we asked people who use opioids, do you want to stop or reduce your use? And back then it was like 78% said yes. I could then go to the legislature and say, most people using opioids actually want to stop or reduce their use. They're like, no, they're all having a great time. I'm like, maybe, but they actually would like to stop or reduce their use. And if we offer them those services in an easy to access way, they will. And we then have shown that with buprenorphine pathways. So this really is a nice cycle we've gotten into that I'm really excited and proud of. And I think one of the things that we want to do more of, and I know I want to do more of, is bring in more also in these presentations of the staff and volunteers and clients as they are comfortable in actually sharing and presenting these data. I'm hoping maybe more on the qualitative side that might give us a chance to do that. Alison does obviously a really nice job of bringing in quotes, and obviously people can be very understandably sensitive about wanting to share who they are in these conversations. On that note, I am going to make a plug actually for a meeting we're going to do in June that you might be interested in. It'll be our third year. It's called Transforming Our Communities, and I can't remember what we're calling it this year, something like Innovations for Harm Reduction, essentially. And it's really an opportunity to bring together really diverse perspectives around harm reduction services and innovations. And I definitely encourage you all to take a look at this. Look at our previous ones. One of the things I did last year that probably was my apex was this session we did around youth and fentanyl that also included videos from youth about their fentanyl use. And it's on that webpage. And I really encourage you to take a look at that webpage. It's really, really rich information with really nice insight. So anyway, I'll stop there. Thank you, Susan, for inviting us to give this talk. I really appreciate it. And thank you everybody for your comments and questions.
Oh, thank you for coming. Brett, you went on camera. Did you have another question to ask?
No, thanks. I just wanted to nod and thanks for the responses. Thank you.
Well, for the very, very first time at the end of one of these meetings, I have the next meeting scheduled up in front of me to announce it. And one thing I think I forgot to mention at the beginning is that these Lunchbox Talks are aimed at bridging public health and the University of Washington, kind of academia and practice. And I think that you guys have really done a nice job of that. So let me add my thank yous to Caleb and Allison and announce our next Lunchbox Talk. And these Lunchbox Talks are every other month. They're on odd months. I think it's the third Tuesdays that we have them. So save the date, May 17th, when Roxanne Karani will come and talk to us about developing and evaluating a video to increase engagement in HIV cluster investigations. And I will use this opportunity also to announce that Roxanne will become co-host of these Lunchbox Talks with me. So welcome, Roxanne. Anything to add?
Nothing from me, and I'm sorry I had to join late today. Thank you, Susan.
I hope to see you all in May. And again, thank you, presenters.
Thank you.